Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is adenomyosis. Adenomyosis is a benign disorder with pathological presence of endometrial glands and stroma in the myometrium, resulting in hypertrophy and hyperplasia of surrounding myometrium. So as we can see here, it is a benign disorder where there is a pathological presence of endometrial glands and stroma in the myometrium, and this presence of endometrial glands and stroma leads to the hypertrophy and hyperplasia of surrounding myometrial cells. It differs from endometriosis. Endometriosis is presence of endometrial glands outside the uterus. One-third cases of adenomyosis remain asymptomatic. Heavy menstrual bleeding is the most common presentation, but patients can have chronic pelvic pain or infertility also, along with adenomyosis or because of adenomyosis. Risk factors which have been identified for adenomyosis are increasing age, especially greater than 40 years, increasing parity, and history of uterine procedures such as caesarean section or dilatation and curettage. It remains a poorly understood condition. Pathogenesis of adenomyosis, there are three theories. First is endometrial injury, which is also called as traumatic injury and repair, TIAR, traumatic injury and repair theory. There is an altered junctional zone. Because of endometrial injury and uterine injury, there is an altered junctional zone, and it leads to invagination of endometrium in myometrium. As you can see here, what is the literal meaning of invagination is folding to form a pouch. So here endometrial layer is entering into the myometrium, folding on itself to form a pouch, as you can see here. So that is how there is an invagination of endometrium into the myometrium. Now, this junctional zone terminology, we come across this terminology so frequently whenever we want to understand adenomyosis. And I think this is the most important slide for understanding adenomyosis, because this forms the basis of this pathological condition. What is junctional zone of the uterus? So many times we use the terminology, but we are not aware exactly what it is. Now here in this diagram, let us see innermost layer of the uterus is endometrium, out of which the dark red one, it is the functional zone of the endometrium or functional layer of the endometrium, whereas the basalis or basal layer of the endometrium is the one which you can see as a light pink in color. So innermost is functional layer, which is getting, there is a proliferation, and then there is a secretory change, and then there is a shading off of the upper layer of the endometrium, which is called as functional layer, which responds to hormones. Whereas basal endometrium is not having any change according to the menstrual according to the changes into the hormonal levels in a menstrual cycle. And this basal layer of the endometrium is responsible for regeneration of the functional layer of the endometrium at the end of menstruation in each cycle. This light pink in color, that is a basal endometrium. Outer to that is the endometrial myometrial interface, EMI, endometrial myometrial interface. And then outside this endometrial myometrial junction or interface, what we have is the junctional zone or inner myometrium. This dark blue in color, that is the junctional zone or inner myometrium. As we can, so what we can appreciate is, on one hand of this junctional zone we have endometrial myometrial interface on the inner side, whereas outer side what it has is the outer myometrium. So it is myometrium only. Junctional zone of the uterus is nothing but the inner myometrium, inner one third of the myometrium. It is also known as subvalvular or subendometrial layer. Why it is called as subvalvular is, there are vessels which are supplying the this endometrium, and this just beneath this layer of the vascular network, we have this junctional zone. That is why it is called as subvascular or subvalvular or subendometrial layer, which is commonly used terminology by radiologists, especially when they look at the junctional zone when we do MRI pelvis. Now, this junctional zone is a highly specialized hormone responsive tissue. It is a highly specialized hormone responsive tissue. There is invagination of basal endometrium through altered or interrupted junctional zone, which leads to formation of adenomyosis, as you can see here. This is the light blue, like light pink, as I said, is the basal layer of the endometrium. This basal endometrium is getting entering into the myometrium through this interrupted or altered or traumatized junctional zone. It enters into the outer two-third of the myometrium and it invaginates. That means it forms a pouch here, and that is how there is a starting point of pathogenesis or starting point for development of adenomyosis. Now, this junctional zone is specially identified on MRI. It can also be identified by transvaginal sonography, especially 2D, 3D sonography now is able to identify it clearly. But MRI is more specific as far as recognition of this junctional zone goes. It is seen as a low signal intensity because of the tightly packed smooth muscle cells which are present around the uterine cavity with less water and extracellular matrix. So it is slightly different structurally as compared to outer two-third of myometrium, this junctional zone. It has tightly packed smooth muscle cells and with less of water and less of extracellular matrix as compared to outer two-third of the myometrium. Junctional zone becomes thicker and hazy in adenomyosis. Because of this disturbance by the entry of endometrial glands and stroma, this junctional zone becomes thickened and it is hazy. It doesn't have a very clear outline in cases of adenomyosis. Junctional zone less than 8 millimeters on MRI is a normal finding, whereas whenever it is greater than 12 millimeter and especially whenever it is greater than 15 millimeters, there is a strong possibility of adenomyosis. This can be diagnosed by doing MRI. This is the most important diagram for all the postgraduate students. My request is you please try to practice drawing this diagram. Clearly we can show how the where exactly is the junctional zone and how it differs from the rest of the myometrium and what is happening. Junctional zone is altered or interrupted, that leads to entry of basal layer of endometrium into the outer myometrial layer, leading to adenomyosis. Second theory for pathogenesis or development of adenomyosis is there is a metaplasia of embryonic pluripotent Mullerian remnants or metaplasia of adult stem cells that leads to development of this endometrial glands and stroma in the myometrium is the second theory. Now, as I said, it is a poorly understood disease and still there is no confirmation about the pathogenesis also. So that is why we are using all these theories currently. Then there is a third theory of pathogenesis, which is very interesting. It is called as from outside to inside invasion theory. Outside to inside invasion is the disease is not entering from endometrial side or inside the uterus. It is entering from serosal surface of the uterus, as you can understand. Outside to inside invasion theory. So here what is the basis for this theory is in deep infiltrating endometriosis, DIE. Whenever there is a posterior deep infiltrating endometriosis, there is increase in focal adenomyosis of outer endometrium. It is called as the short form which is used for that is FOAM, FOAM. It is focal adenomyosis of outer endometrium. The short form uses FOAM, and this is seen quite frequently whenever there is a deep infiltrating endometriosis, especially into the posterior compartment of the pelvis. Now, this is what we can see is the urethra and the bladder. Then this is your cervix and the uterus, and this is bowel, sigmoid colon. So, and this is the pouch of Douglas. So what is happening is here there is a deep infiltrating endometriosis, so that there is a nodularity in the pouch of Douglas. Now, whenever this is present, there is a endometriosis which is deep enough to be present between the vagina and the pelvic tissue posteriorly, and that is the reason for dyspareunia, severe dysmenorrhea will be the presentation, or sometimes even difficulty in defecation is the presentation with this DIE, deep infiltrating endometriosis, which can only be diagnosed by doing MRI. Now, there is a what is seen is whenever this deep infiltrating disease is there in the posterior compartment of the pelvis, it is associated with increased presence of focal adenomyosis in outer myometrium. It is not in the near the junctional zone, but it is near the serosal surface, and that is why this theory has a some ground, or it has been formed, that there is an invasion from outside to inside. These endometrial cells and stroma are invading the serosal surface of the uterus and entering into the outer myometrium, leading to the development of focal adenomyosis of outer myometrium or foam. So there is a retrograde menstruation, there is posterior this deep infiltrating endometriosis, and then there is a development of this focal adenomyosis of outer myometrium. It is a MRI diagnosis. Now, what is interesting is even with anterior whenever there is a bladder endometriosis, there is increase in anterior foam. What is anterior foam? Is anteriorly there is a focal adenomyosis of outer myometrium. This is very interesting terminology, and I was quite surprised to find this terminology, FOAM, that there is a presence of adenomyosis, focal adenomyosis, which is specially affecting the outer myometrium, and that is why there is a ground to uh, s- uh, uh, apply this theory at least to some cases of adenomyosis, from outside to inside invasion theory. Adenomyosis is currently diagnosed as diffuse adenomyosis when it is affecting the myometrium all over, or as a focal adenomyosis. That is one way. Now, there are so many classifications which are being considered, and if we go through the literature, there are so many classifications which have been proposed by various researchers, such as whether adenomyosis is affecting to say whether it is anterior wall of uterus, posterior wall, right lateral, left lateral, fundal region, or whether how much is the myometrial involvement, whether it is up to one third or from one third to two-third of myometrium, or greater than two-third of the myometrial involvement, or whether it is a cystic associated with cystic change in the myometrium, or it is associated not associated with cystic change. All these are the various ways of classifying adenomyosis, but no classification at present has been proven internationally, and only classification which we are using currently in practice is whether it is a diffuse adenomyosis, where the change in the myometrium is all around uniform. There will be uterine enlargement which will be uniform uterine enlargement, that is diffuse adenomyosis. And second is focal adenomyosis, where this change is seen in only at one specific point, then it is called as focal adenomyosis, which is also called as adenomyoma, as you can see here. Only here there is a change at some one particular place in the myometrium, rest of the myometrium is healthy. There is in the focal adenomyosis, there is exaggerated myometrial proliferation around foci of ectopic endometrium. It is also known as adenomyoma. It is a closest possible differential diagnosis for leiomyoma or fibroid uterus. It is sometimes clinically it is very difficult to differentiate, and if we go only by ultrasonography, then sometimes even when we start doing myomectomy, that is the first time we realize that our diagnosis is wrong. It is not a case of leiomyoma, but it is a case of adenomyoma, because we do not get a plane of separation between the lesion and surrounding myometrium in cases of adenomyosis, because it is entering like that all around. There is no specific plane of separation. That is the reason it is very difficult technically to do adenomyomectomy. And whenever we try the excision, technically it can be difficult, and it is associated with increased bleeding. On the other hand, this is how leiomyoma is present with a pseudocapsule. Pseudocapsule is formed by the compressed myometrial cells around the leiomyoma, and we get a smooth plane of separation, and it is very satisfying to do a myomectomy. As all of you who have done myomectomy must have realized that it is so much of there is so much of fun and excitement. Whenever a large leiomyoma we can remove very easily because of the presence of this pseudocapsule. So technically doing myomectomy, what is challenging is mainly how we deal with the open vessels after the removal of myoma. Removal of myoma is usually very easy because we get a plane of separation. But adenomyoma, whenever we want to excise adenomyoma, it is always a difficult procedure. The reason is there is no actual plane of separation here. It comes out in piecemeals, and it is comparatively not a very smooth surgery, and it leads to opening up of more blood vessels, leading to increased intraoperative blood loss. So that is the main difference between this leiomyoma and adenomyoma. Really, as far as surgical removal goes, that there is no plane of separation for adenomyoma. There is a plane of separation leading to ease in the removal of leiomyoma. Prevalence of adenomyosis, which has been given by various researchers, is around 1% of the general population. Previously, it was diagnosed after hysterectomy on the basis of histopathology for many years, but now in the last few decades, it is being diagnosed increasingly with imaging, such as ultrasonography and MRI, is helping us to diagnose this entity before doing a hysterectomy. Previously, it was mainly identified by as a disease which is mainly found in multiparous women or women having prior cesarean section or any prior uterine surgery, and that is why which it goes with this TIAR theory. That is, it is traumatic injury and repair. TIAR is traumatic injury and repair theory. So this theory holds true because the disease is found more commonly in multiparous as compared to nulliparous women. It is more commonly seen whenever patient has a prior history of cesarean section or prior uterine surgery in the form of any evacuation, dilatation, curettage, like that. It was mainly identified as a disease of elderly women, and especially 40 to 45 years it was diagnosed maximally whenever it was diagnosed with the histopathology, mainly by the histopathology. But now with the imaging we are able to this diagnose it more and more, even in women having infertility or in younger women or women having dysmenorrhea, abnormal uterine bleeding, or both. In these women pre-operatively before hysterectomy, we are able to diagnose it now in last few decades with the help of imaging. So relatively it is a new entity, if we can say, in gynecology. It is relatively as compared to leiomyoma, recognition of adenomyosis as a separate entity is a not a very old concept. It is relatively new. I can say that around last 2 decades it is emerging as a separate entity apart from endometriosis as a distinct entity. Otherwise, it was called as endometriosis interna and not given much of a importance. But since FIGO has gone for this palm coin classification system and identified AUBA, that is adenomyosis, as a structural cause of AUB, there is more and more focus which has been identified. And as we are diagnosing it increasingly with imaging, there is a realization that it is not a disease only affecting the elderly women, it affects young women also. So there is a shift in understanding, complete change in our understanding, that it is not a disease only for multiparous women, it also affects women having infertility. It is not only affecting elderly women, it affects young women also. All this is possible because of increasing use of imaging in the diagnosis of adenomyosis. clinical presentation, most common symptom is abnormal uterine bleeding. And in abnormal uterine bleeding, there are two symptoms. Either patient can present as heavy menstrual bleeding, where there is a increased blood loss or prolonged bleeding in a menstrual cycle, and it is seen in 40 to 60% of cases of adenomyosis, or patient even can present with irregular cycles. Second common symptom is dysmenorrhea, which is seen in 15 to 30% of the cases of adenomyosis. Less common symptoms are dyspareunia, chronic pelvic pain, and infertility. Coming to signs, uterine enlargement is the most first prominent clinical feature whenever we examine a patient with adenomyosis, but it remains usually a pelvic organ. Typically, it remains a pelvic organ, and it is less common to see a case of adenomyosis where uterus is palpable per abdominally. Usually, it is less than 14 centimeters or 14 weeks of pregnant uterus. Whenever there is a diffuse adenomyosis, it leads to symmetrical enlargement of the uterus, whereas in adenomyoma, focal adenomyosis, there will be irregularity of the uterine enlargement. A bulge might be palpable on one side, which that is why it forms a close differential diagnosis for leiomyoma. Consistency of the uterus can be boggy consistency, and uterine tenderness is present, which is not there in leiomyoma. That is one of the feature which helps us to differentiate clinically between leiomyoma and adenomyoma or adenomyosis. Is uterus is tender in adenomyosis. Now this adenomyosis, as I said, part of FIGO etiological classification of AUB. It is in the palm. Palm is structural causes, coin is non-structural causes of abnormal uterine bleeding. And out of this, polyp, adenomyosis, leiomyoma, endometrial hyperplasia, and malignancy. These are the four structural causes, and adenomyosis forms one of the structural cause of abnormal uterine bleeding, which has been proposed by in 2011 by FIGO as a etiological classification of abnormal uterine bleeding. Now, why there is heavy menstrual bleeding in adenomyosis? There is increased surface area of endometrium. There is increase in total volume of endometrium and endometrial glands, and there is increased vascularization of endometrium. And this heavy menstrual bleeding correlates with extent of myometrial invasion. How much is the invasion? Dependent on that it is directly proportionate. This myometrial invasion is directly proportionate with the severity of heavy menstrual bleeding. What are the coexisting conditions with adenomyosis? Now, adenomyosis and fibroid or leiomyoma, that is very common. And that is the reason why so many times we do hysterectomy for leiomyoma. And then we are surprised when the histopathology report shows presence of leiomyoma as well as adenomyosis. And sometimes it is pre-surgery, we miss the diagnosis because main focus is on leiomyoma. Multiple fibroids are there, and even by ultrasonography, we are less likely to appreciate presence of adenomyosis. But these two conditions are very commonly coexisting. And in 50% of the cases of adenomyosis, there is a presence of leiomyoma. Whenever there is a combination of this adenomyosis and leiomyoma, it leads to more severe dysmenorrhea or severe chronic pelvic pain and severe dyspareunia. So whenever a patient of fibroid uterus presents with severe dysmenorrhea, chronic pelvic pain, or dyspareunia, it is an indication to search for adenomyosis. Second condition coexisting with adenomyosis is endometriosis. In 10% of the cases of adenomyosis, there is a presence of endometriosis, and it is more adenomyosis is more commonly present whenever there is a deep endometriosis rather than superficial endometriosis. Now, again, to stress once again, adenomyosis and endometriosis are two distinct entities. These were considered together in the previous, even if we see the classification of endometriosis, one of the classification includes adenomyosis as a type of endometriosis, which is not uh, current thought. The current thinking in the gynecology is very clear that endometriosis is presence of endometrial glands and cells outside the uterus. whereas adenomyosis is presence of endometrial glands and endometrial stroma in the myometrium. So that is why these are two distinct entities. Whenever a third condition which is coexisting with adenomyosis is infertility, and it has been seen that whenever a patient, a group of infertility cases undergoing assisted reproductive technology, if we see say 100 cases, in 25 cases there is a presence of adenomyosis. It is as high as that much, that women who are having infertility and who are going for assisted reproductive technology, in 25% of these women there is a presence of adenomyosis. It is that high. So these are the three coexisting conditions: fibroid, endometriosis, and infertility. And this is the newest understanding for us, that this disease is affecting the women. Even fertility potential is reduced because of the presence of adenomyosis, and it can be one of the cause for infertility. Is a very new thought for us, which is there since last 2 decades only. It was not there before that. When I was doing my post graduation, we never had this concept of association of adenomyosis with in cases of infertility. Now, why there is dysmenorrhea in adenomyosis? There is increase in oxytocin receptors in cases of adenomyosis. There is increase in prostaglandin production, and it leads to increase in uterine contractions, and that is why there is a associated. It is a very typical presentation of adenomyosis, that there is a new onset dysmenorrhea. It leads to secondary dysmenorrhea. Now, I want to uh, uh, again remind this our viewers that primary dysmenorrhea is dysmenorrhea which is present usually since menarche, whereas secondary dysmenorrhea is a dysmenorrhea which is because of underlying pelvic pathology. And most the number one cause of secondary dysmenorrhea is endometriosis, and number two cause is this adenomyosis. Onset of excuse me, onset of dysmenorrhea is in later years. In cases of adenomyosis, it is observed in women with a age greater than 35 years. Pain onset is few days before onset of menses. Typically, secondary dysmenorrhea, pain starts few days before onset of menses, whereas primary dysmenorrhea, pain initiates with the initiation of menstruation. So it is a common, one of the common cause of secondary dysmenorrhea. Adenomyosis leads to dysmenorrhea, and type of dysmenorrhea is secondary dysmenorrhea. Now, how adenomyosis leads to infertility? There is abnormal thickening of junctional zone of myometrium. We have already seen in the previous slide that as the invagination of the basal endometrium takes place, it leads to the hyperplasia, hypertrophy of surrounding myometrial cells, ultimately leading to thickening of junctional zone of myometrium. That leads to abnormal uterine peristalsis. There is a junctional zone hyperperistalsis in cases of adenomyosis. It also, there is abnormal uterine peristalsis. There is impaired implantation also. Implantation is also getting adversely affected because of the presence of adenomyosis, as utopic, and there are endometrial changes in the utopic endometrium. Now, this is important terminology. Utopic endometrium is the endometrium which is present at the normal site, that is the inner lining of the uterine cavity, whereas ectopic endometrium is the endometrium which is present either in the myometrium as in adenomyosis, or outside the uterus as in endometriosis. So utopic endometrium means the endometrium which is lining the uterine cavity, and there are changes, molecular changes are observed in cases of adenomyosis in this endometrium. There is more of inflammatory change, reaction is there, and overall molecular changes are there, abnormal molecular changes resulting in impaired implantation in cases of adenomyosis. Now, this hyperperistalsis is responsible for altered sperm transport in cases of adenomyosis, contributing to infertility. Now, there is another interesting concept which is emerging recently, that adenomyosis can adversely affect the pregnancy outcome. It is associated with recurrent pregnancy loss. So it not only leads to infertility, even if patient conceives, there is increased risk of recurrent pregnancy loss whenever there is a presence of adenomyosis. Even this adenomyosis is leading to abnormal placentation, ultimately leading to all the problems with abnormal placentation, such as hypertensive disease in pregnancy, or fetal growth restriction, which is there whenever there is abnormal placentation. All these are also increased in women having adenomyosis. Is the most recent concept, impact of adenomyosis on pregnancy outcome. Now, even adenomyosis has been identified as a risk factor for cesarean section scar pregnancy. Now, in ectopic pregnancy, the latest one which is emerging as a type of ectopic pregnancy is a scar pregnancy, where the implantation takes place in the cesarean section scar itself. And one of the risk factor for this scar pregnancy, which has been identified by studies, is adenomyosis. So it is a small topic. When I started preparing for this topic, I thought that it will be a very short video and hardly few slides will be there. But as I started this reading about it more and more, especially in the recent advances related to this topic, there were so many surprising facts which were emerging, and it is increasing the interest in the topic in the recent years, especially its impact on fertility, its impact on pregnancy outcome. These are absolutely recent changes as far as our understanding of this disease goes. Now, how it is diagnosed? There is a clinical suspicion. We have already seen symptoms and signs, and then we go for imaging. As the first line imaging technique is transvaginal sonography for the diagnosis of adenomyosis. Now, if there is any doubt about the diagnosis by TVS, then for confirmation, we go for MRI. MRI is more specific than transvaginal sonography for the diagnosis of adenomyosis. Now, another addition to the diagnostic tools is hysteroscopy. That is very interesting in the as we use more and more hysteroscopy, especially for a woman having infertility. What has been observed is hysteroscopy also helps us to identify the group of women who are likely to have adenomyosis. There are endometrial changes which are seen by hysteroscopy, such as there is hypervascularization, endometrial defects are identified by hysteroscopy, and submucosal hemorrhagic cysts are also seen by doing hysteroscopy. So that these changes mainly point towards our possibility of a woman having a presence of adenomyosis. And post-hysterectomy histopathological examination diagnosis is still considered as a gold standard for diagnosis of adenomyosis. So if we are asked what are the various ways of diagnosing, one is clinical suspicion. First investigation of choice is transvaginal sonography. Confirmation is by MRI, preoperative confirmation. Hysteroscopy also helps in the diagnosis, and a gold standard remains histopathological examination of the uterus after hysterectomy. Now, diagnosing adenomyosis is still a challenge, as there are no definite histopathological or imaging criteria available. Currently, histopathological criteria which is used by most of the pathologists is presence of endometrial glands and stroma, at least one low power field from basal endometrium. So what we have seen is the endometrial myometrial interface. Beyond this endometrial myometrial junction, if there is a presence of endometrial glands and stroma, at least one low power field, beyond at least one low power field, then it is diagnosed as a case of adenomyosis. Now, continuing with imaging in adenomyosis, this slide I have taken from my previous presentation of AUB, where this slide was in as a AUBA, that is adenomyosis. Now, all these we can see a 1, 2, 3, 4, 5, 6, 7, 8. 8 changes are seen on ultrasonography, and this has been called as MUSA criteria. What is MUSA? Is morphological uterus sonography assessment criteria 2015. which was proposed in 2015 to diagnose adenomyosis. MUSA is morphological uterus sonography assessment criteria. There are total 8 criteria, and presence of greater than or equal to 2 features is suggestive of presence of adenomyosis. This overall it has a less specificity, though there are so many criteria. Multiple presence of multiple criteria increases the diagnostic accuracy, but presence of only 1 or 2 criteria is not associated with a definitive diagnosis of adenomyosis. In that sense, it has less specificity. Around it has been given from 60 to 80% of the cases there is a correct diagnosis of by using this MUSA criteria. What is MUSA criteria? This all of you must be knowing by heart. What are the morphological sonography or uterus sonography assessment criteria, or when how on the how the by ultrasonography what changes are seen to diagnose a case as having adenomyosis is a very likely question you might be asked in any case of AUB in your practical examination also. That if you say I will do ultrasonography to diagnose adenomyosis, next question will be how you diagnose adenomyosis by ultrasonography. So there are these are the features. Asymmetrical myometrial thickness is seen when we do transvaginal sonography. Presence of myometrial cyst has greater specificity for adenomyosis as compared to other changes. Whenever the cystic lesions are identified in the myometrium, then we call it as myometrial cyst, and it is associated with greater possibility of having adenomyosis. That is why it is considered as a one of the specific sign for the diagnosis of adenomyosis, myometrial cyst. Then hyperechoic islands are seen. There is a shadowing which is called as fan shaped shadowing, which is one of the clinical feature, radiological feature or ultrasonography feature of presence of adenomyosis. Then subendometrial lines and burrs are observed by transvaginal sonography. There is a translesional vascularity. That means a lesion is seen and in between vessels are seen on Doppler. Whereas on the other hand, what is seen in a leiomyoma is the vessels are present at the periphery and center remains avascular. Whereas in if there is a focal adenomyosis, translesional vascularity is seen. There is an irregular junctional zone which is suggestive of adenomyosis, and especially junctional zone is seen more clearly by 3D ultrasonography. And interrupted junctional zone is also one of the feature. So you can remember G for junctional zone there are 2 features: irregular or interrupted. Then presence of these birds and lines, or presence of translesional vascularity, hyperechoic islands, shadowing, and myometrial cyst. And most likely what can be appreciated is asymmetrical myometrial thickness. So these are the 8 criteria: MUSA, MUSA criteria, and presence of greater than or equal to 2 is more uh, is associated with a is required to diagnose a case as a case of adenomyosis, and greater the number of criteria, more is a possibility of having correct diagnosis of adenomyosis by ultrasonography. Now, MRI is used for confirmation, especially to differentiate between adenomyosis and fibroid. MRI helps a lot. Or whenever there is, as we have already seen, there is a coexistence of fibroid and adenomyosis, and then in that case, these are the cases whenever the adenomyosis is present in a case of leiomyoma, it is more difficult to diagnose it preoperatively by ultrasonography, and in these cases, especially MRI helps. Whenever the junction zone is thickened and thickness is greater than 12 millimeters, especially in late proliferative phase. So whenever MRI is done, it should be done in late proliferative phase, because otherwise junctional zone thickness increases during menstruation. So if MRI is done during menstruation, it can lead to false positive diagnosis of adenomyosis. That is why it is this junctional zone thickness, if it is more in late proliferative phase, it is more likely to be associated with a correct diagnosis of adenomyosis. Focal adenomyosis poses greater diagnostic difficulty because it is ultrasonography sometimes more difficult to differentiate between adenomyoma and leiomyoma. Now, what are the findings to be noted by a sonologist whenever we are suspecting adenomyosis? What are the features of adenomyosis? Out of these 8 features, again I will repeat, 2 features are related to junctional zone as interrupted junctional zone or irregular junctional zone. Then subendometrial presence of cyst, lines or bursts, or presence of hyperechoic lesions or translesional vascularity and irregular myometrial thickness or enlargement. All these are the features of adenomyosis. So, what are the features found in a given case are to be noted by sonologists. Sonologist has to note the location, whether it is present all around or whether it is present that is diffuse or whether it is present at a particular place. So, which wall of the uterus is getting affected? So, location is to be noted. Then whether it is local or diffuse to be noted, whether there is an association of cystic change, because myometrial cyst, as we have already seen in last slide, it is more specific for diagnosis of adenomyosis. Uterine layer involvement, how much uterine layer is involved or which uterine layer is involved, as in foam. FOAM is focal adenomyosis of outer myometrium, which is seen in deep infiltrating endometriosis. The outer layer of the uterus is uterine myometrium is involved. So that is why uterine layer involvement is to be mentioned, whether it is the outer 1/3 of the myometrium or whether it is affecting the junctional zone and inner part myometrial layer. Extent of the disease, whether it is affecting the myometrium to the extent of, as we have already seen, less than 25%, 25 to 50, 50 to 75, greater than 75, so on. And size of largest lesion or largest affected area to be noted by sonologist. So that is what is expected. Now, if you get a report of adenomyosis, you please ask your sonologist to comment on all these points because it helps in more clinical correlation and it helps in the management plan also. That is why you need a sonography report or MRI report which is including all these features whenever a case is reported as a case of adenomyosis. MRI is indicated whenever the transvaginal sonography is inconclusive for the diagnosis and also whenever there is suspected associated pelvic pathology, especially presence of leiomyoma will be an indication to do MRI to differentiate whether it is a case of adenomyoma or leiomyoma or whether both are coexisting. What are the principles of treatment of adenomyosis? The mainstay in the treatment is symptom control to improve quality of life. Adenomyosis is adversely affecting quality of life significantly because it is associated not only with heavy menstrual bleeding but with dysmenorrhea also, or some cases might have severe dyspareunia or chronic pelvic pain, and that is ultimately, and it can affect the fertility also. That also we are now understanding. It can affect the pregnancy outcome also, and that is why this condition also leads to the reduction in the quality of control. And our main aim of management is symptom control to improve quality of life. Definitive treatment for adenomyosis still remains hysterectomy, but other conservative ways of treating the disease are now being tried more and more women as we are diagnosing it in younger women, especially those who have not completed family. Endometrial ablation can be done in cases of it is adenomyosis is not a contraindication to do endometrial ablation for heavy menstrual bleeding, but it is associated with increased failure rate. Whenever in cases of adenomyosis we are doing endometrial ablation, it is actually the endometrial glands and stroma in myometrium. So we are not taking not able to take care of that, and that is why there is an increased failure rate of endometrial ablation whenever adenomyosis is present. And post ablation pain also, the risk of post ablation pain also increases with the presence of adenomyosis. Medical management still has a questionable place in management of adenomyosis, and as for endometriosis, similar medical management is also tried in adenomyosis, such as non-steroidal anti-inflammatory drugs, tranexamic acid, OC pills, progestins. What has been emerged as effective medical management is use of LNG IUS, levonorgestrel releasing intrauterine system. This LNG IUS leads to reduction in uterine volume and dysmenorrhea in cases of adenomyosis, apart from leading to reduction in heavy menstrual bleeding also. But LNG IUS can only be used in women who do not want pregnancy. That is the limitation of its use, because it will act as a contraceptive also. GnRH agonist antagonists can have also been found to be effective in cases of adenomyosis, but these are less commonly used because of the associated side effects and associated high cost. There is a place for the use of this GnRH agonists and antagonists whenever we are going for IVF in a woman having adenomyosis. So whenever IVF is being planned in a woman with adenomyosis, before going for IVF for 3 to 6 cycles, months, if GnRH analogs are used, it improves the success rate of IVF. Dynogest, especially Dynogest, is a progestogen which has been found to be very effective in endometriosis. Similarly, it has been found to be very effective in women with adenomyosis. So Dynogest, LNG, IUS, OC pills, these are these that for the out of these three, it forms first line medical treatment for heavy menstrual bleeding or pain caused by adenomyosis. So first line treatment can be OC pills or use of LNG, IUS or Dynogest. GnRH and agonists remain second line treatment, medical treatment for heavy menstrual bleeding or pain. And whenever it is to be used for greater than 6 months, then add-back therapy needs to be used. Add-back is we have to add estrogen mainly to prevent development of osteoporosis because of the prolonged use of GnRH agonist. Uterine artery embolization has been tried in women who have completed family but who want uterine preservation, who are not willing for hysterectomy. This is a group of women completed family but are not willing for hysterectomy. These are the women who are the candidates for uterine artery embolization, which has found to be effective by some um, according to some researchers. Minimally invasive thermal ablation procedures such as this HIFUS, high intensity focus ultrasound, or percutaneous microwave ablation, or radio frequency ablation, all these thermal ablation procedures are under research as a treatment modality for adenomyosis. It is still not used in clinical practice, in other words. It is under research only. All these are to be tried under research. Uterine artery embolization has been tried in clinical practice also, but all these other procedures are under research. Adenomyosis excision. If it is a focal adenomyosis, it can be tried, but it remains a challenge because of, as I said, increased intraoperative bleeding is there. Now, open surgery is specially indicated whenever the adenomyosis is a diffuse one, whereas laparoscopic or robotic approach can be tried for focal adenomyoma excision. Now, whenever this adenomyoma excision is done, there is a questionable impact of this procedure on fertility or pregnancy outcome. And we have to remember that it weakens the uterine myometrium, and there is a need for pre-labor cesarean section because of a high risk of uterine rupture after doing a adenomyomectomy. And hysterectomy remains the gold standard in the management of adenomyosis. To summarize, adenomyosis is a new emerging entity in recent years. The pathogenesis or the condition itself is not still well understood. Transvaginal sonography, especially the 2D or 3D ultrasonography or MRI, helps in diagnosis without going for a hysterectomy histopathological examination diagnosis. Now, more and more focus is shifting for the presence of this disease in younger women in the last few decades. And there is an emergence of the understanding that this adenomyosis might be playing a role in cases in infertility as well as for pregnancy outcome. medical or conservative surgical managements are being tried in more and more women in the last few years. Now, these are the references. I have gone through the textbooks, Steeland, Spirops, and Novax. Apart from that, this American Association of Family Physician guideline on adenomyosis diagnosis and management has helped me a lot in understanding the disease. Then there is a recent advances in understanding and managing adenomyosis. This uh, review article has also helped a lot to know increase my understanding related to the current concepts associated with this disease, and Canadian guideline also has helped. So this is a disease or this is a condition where I had to search more outside the textbooks also to mainly have the understanding of recent advances and current concepts associated with adenomyosis. Thank you.